so let's get started. Once again, we're pleased to be bringing you this IHSPR policy round, which will share findings from research supported through CIHR's Healthcare Renewal Policy Analysis funding opportunity. This funding opportunity was launched in 2011 as part of the Evidence-Informed Healthcare Renewal Signature Initiative. Healthcare Renewal Policy Analysis grants were designed to support the generation of health policy analyses and to offer policy and decision makers evidence-informed policy options on health and health system outcomes for healthcare renewal issues of high importance. A selection of research funded through this funding opportunity will be featured in upcoming policy rounds, as well as on the EIHR website. And the link for those research profiles we'll put on the chat mechanism so that you can access it on your screens. So the learning objectives for today are to review the results of a comparative analysis of primary healthcare policies in 3 Western provinces, discuss macro-level structural barriers to innovative collaborative service delivery, identify policy levers to advance team-based primary health care, and finally, to understand the policy implications of these research levers on the healthcare system. So an outline of how things will flow today, in a moment I'll introduce the speakers, and then we'll first hear from the researchers to provide you with some background and context and an overview of the work that they've undertaken. And after that, we'll shift gears to a conversation about the policy implications of the research presented. And then following that, we'll take questions through the chat mechanism and help to facilitate some continued connections and dialogue. I do want to encourage you throughout the webinar to please feel free to use the chat box to correspond with other participants on the webinar and share information. And I just want to mention also that as the webinar closes, you will see a survey pop up on your screen, and we would appreciate you taking a couple of minutes just to let us know what you thought of today's session. So thank you in advance for that. So to introduce the speakers first, I'd like to introduce Dr. Esther Suter. She has more than 20 years of experience in health research with a focus on interventions to enhance collaborative practice, how to achieve integrated health systems, and exploration of innovative care delivery models. She has a special interest in complex adaptive systems and human system dynamics and how tools and approaches from these fields may be used to achieve transformative change in healthcare. Our second presenter today is Dr. Louise Naismith. She is a professor in the Department of Family Practice at UBC. And in 2007, she became the principal of the College of Health Disciplines at the University of British Columbia. And in 2014, the Associate Provost of Health. Her scholarship has focused on medical education across the continuum, integration of care for chronic illness, and interprofessional education. She has been involved in an accreditation of education programs and is currently a member of the Canadian Council for the Accreditation of Pharmacy Programs. So those are our research presenters today. And you'll also be hearing from Carolyn McCauley. And with over 20 years of experience as a registered dietitian and healthcare leader, Carolyn has experience in all aspects of healthcare provision. Her passion for community development and primary healthcare is reflected in all of her work, especially through her role in Alberta Health Services within the primary healthcare as manager for zone supports, allowing her to work with a variety of stakeholders to improve primary care. So that's a highlight of our speakers today. And right now, I'm going to turn things over to Dr. Esther Suter to kick things off with the research presentation.
Thanks, Jennifer. Thank you very much for the introduction, and welcome everybody to this seminar. I'm very pleased to be able to present the findings of a very recent policy synthesis to you here today. And okay, so I don't seem to be able to move the slide. Should I be able to move the slide?
So Esther, if you click on the screen and then press the slide forward arrow, that should work.
Okay, great. My apologies. So first of all, I would like to recognize my team that has been working on this policy analysis, the core team that has done the heavy lifting, but we had a very exclusive expert team that has supported and advised us along the way from the 3 provinces. So thank you to all of them. And we also would like to recognize the funding that has been provided from the Canadian Institute of Health Research. So team-based primary health care has been on the agenda for many, many years, and it was in the Health Accord that really a firm commitment was made that everybody should have access to an interprofessional team or team-based care. However, in terms of progress, it's not entirely clear how much Canada has actually progressed. As you know, policy development and implementation are under provincial jurisdiction, so each province pretty much decides the way they would like to implement health care and the focus they put on. And so that makes it a little bit challenging in terms of a national agenda. So there is no national framework that would direct the provinces in terms of team-based primary health care. And as a result, there have been some critical voices that suggest, you know, we haven't really moved beyond a series of pilot projects, and that the lack of a cohesive approach to primary health care reform is really hampered by a lack of a national vision. So we were interested in seeing basically what do the different provinces do in terms of policies that support primary health care or team-based care. And so we chose 3 provinces, British Columbia, Alberta, and Saskatchewan, for our policy analysis. And basically, we wanted to ask the question, how do the policies speak to primary health care, and in particular to team-based primary health care? Are there any gaps in the policies? What level of detail can we find? And what could we potentially learn from the 3 provinces that would lend itself to a more national focus or a national agenda? Based on our policy analysis, we developed 5 policy imperatives or policy levers to advance team-based primary health care service delivery. And that's a critical part of the type of grant that we received. A very quick overview over the design and methods of our study. In the first step, we did a fairly comprehensive context review of the 3 provinces and also a national context review, just to really understand what kind of socioeconomic political factors were evident in the different provinces during our examination period. So to understand what influences healthcare might have experienced during that time. And then we retrieved publicly available policies from 2007 on and really had a very good look at those policies, extracted relevant information, and kind of developed narratives for each of the provinces first, and before we actually did a comparative analysis across the 3 provinces. So we looked for unique situations in each province, but we also looked for communalities across the 3 provinces. Based on these narratives, we performed some key informant interviews. So we provided important key decision makers, planners, practitioners in the 3 provinces with the provincial narrative. So they had an opportunity to comment on the narrative, to fill in some blanks, to validate it, but also give us further explanations if we felt there were some gaps. And that was really helpful for us too in terms of putting the policies in the right context, because not everything is kind of visible from the policies, but there's a lot of information that gets lost. Based on the narratives, then we finalized our synthesis, and we identified a number of policy imperatives. In the beginning, we had about 15 topics that emerged that seemed highly relevant. And out of these topics, we sort of used the prioritization process with a ranking procedure to come up with the top priorities that people felt were most relevant to move team-based primary health care forward. Those policy imperatives were then discussed at a policy roundtable with 15 stakeholders, a mixed group from BC, Alberta, and Saskatchewan to further validate the imperatives, but also add more context around them. Now, what I would like to do is first give you a very brief overview of each of the provinces in terms of what has happened that's relevant to team-based primary health care. So British Columbia, of relevance was 2003, the full-service family practice program was launched. And that was an important program that to really enhance access to health services and provide financial incentives for priority areas. In 2007, the Primary Healthcare Charter was developed, which introduced the integrated health networks. These are important networks that formalize the links between family physicians, health authorities, and community resources. They don't speak specifically, though, to team-based primary health care. In sort of between 2007 and 10, there were big fund infusions, mainly targeted to support family physicians. So in BC, clearly family physicians have a very leading role in terms of primary health care. The Health Professional Act in 2008 was interesting because it included a clause that really encourages collaboration between providers of all kinds of health disciplines. So that's probably one of the first times that this is very formalized in BC in terms of the expectation that there shall be collaboration between the healthcare professionals. And then also important, in 2014, the Miscellaneous Statutes Bill 17, which expanded the nurse practitioner scope of practice in British Columbia. However, what was interesting to note, though, is this wasn't done within the context of team-based care, so it wasn't really used as a tool to perhaps facilitate team-based collaboration. Alberta, the situation is quite different. So in 2003, the primary care networks were launched. This is really sort of the primary infrastructure for primary care in Alberta. They're physician-led. They received funding where they had an opportunity to hire interprofessional team members, which sometimes occurred, but sometimes not. So there was a somewhat critical report, I believe that was in 2012 by the auditor, that criticized that maybe the primary care networks haven't quite achieved what they were supposed to, and so that triggered a number of reactions. In 2008, Alberta Health Services was created, which shifted sort of the policy landscape a little bit. 2012, the family care clinics were created. That was really a big election topic by Alison Redford at the time. 3 pilot clinics were opened at the time, and a number more were announced. Actually, initially, there were over 80 that were announced. But when Alison Redford resigned, the agenda changed again, and so I think we're sticking with those 3 and 9 family care clinics that are being funded right now. Family care clinics were interesting from a policy perspective because they're quite explicit in terms of the team requirements. So there are requirements to have different team members on accountability and governance structures. Shortly followed was the Primary Care Network Evolution Framework, which saw a little bit of a revamping of the primary care networks, also moving more towards a team-based primary healthcare approach. And then also very interesting, rather late, the development of the primary healthcare strategy in Alberta, which was only released last year, which is a very important guiding document. So a lot of the primary healthcare structures in Alberta actually predated the official strategy. Now, lastly, Saskatchewan has a very long history of team-based primary health care. So in 1997, Primary Health Services Initiative was launched, and they really saw the development of voluntary primary health care sites where the focus was on providing access and coordination of primary health care services through the development of teams and to integrate prevention and health promotion. So that's very unique within the 3 provinces that already at this early stage there was a specific focus on team-based care. That was reconfirmed in 2002 with the Action Plan for Primary Health Care, which again talks about managed networks and teams of healthcare providers. And then again in 2011 and 2012, the 2 primary healthcare framework, the one by the Medical Association, the other one by the government, which continued in their development of multidisciplinary teams and really state clearly a core function for primary healthcare teams in service delivery. So as you can see, we have quite a different history for the different provinces, which made it quite interesting to look at the policies. Now here the findings of our comparative analysis. A couple key issues that emerged. The first bullet is there is an overarching policy outlining a strategic direction for primary health care. So each province really has a key document that sets out the vision for primary health care. But as I mentioned before, some of the documents were developed rather late, and a lot of the primary healthcare developments predate that strategy. But I think it's important because on a go-forward basis, those documents will certainly have a greater impact on the healthcare strategies. When we looked at the policies, we noticed that the conceptualization of team-based care is very broad. So typically, the documents would include primary health care services, community-based services, public health, mental health, and social services. So it's really a very inclusive vision, and it doesn't really outline specifically what kind of team members should be involved. On the one hand, that makes it difficult to really put the right teams in place. On the other hand, it offers a lot of flexibility to be sensitive to the different contexts. Another point we noted was that team-based primary health care in all 3 provinces is positioned within the wider context of system transformation. So it's really seen as one way to transform the primary health care system. However, what we found surprising and a little bit disturbing is that there was no evidence system alignment in the policies. So the different policies really are not very cohesive, and sometimes they speak to different issues in slightly different ways. There is also a lack of clarity and detail on structures, accountability, scope of practice in the policies. So, for example, in terms of leadership, it's more implied than made specific, explicit, that physicians are typically the leaders of the teams. This can also be seen that a lot of the funding is typically funneled through the physician agenda. It doesn't really talk to detailed structures, scope of practice. There were a couple documents that allude to scope of practice and how important it is that in team-based primary health care that everybody can actually work to their full scope of practice. However, they don't really talk to issues of role clarity or how to negotiate scope of practice if there is overlapping scope. And so I think on an implementation level, there might be a lot of challenges because that direction is missing. Similar, no detailed operational guidance for implementation. And you could argue maybe, our policy documents that we reviewed were too high level, and that's not the role of those documents to really provide that guidance. So it might well be that we missed the key implementation documents. And then the last point here is around monitoring and evaluation. There were only a few documents that had clear expectations about performance monitoring and how to assess the performance of team-based care in the bigger context. So based on our synthesis, we came up with those 4 policy imperatives or policy levers, however you would like to call it. So the first one is around aligning health system goals, policies, workforce, and structure. The second one, develop appropriate and sustainable compensation models, invest adequate resources to support system change, and then the last one, integrate collaborative practice metrics in primary healthcare monitoring and evaluation. I'll just speak to each one in a little bit more detail. So the first one, as I mentioned, there's a lack of alignment between the different policies at different levels. So we saw a lack of alignment or a misalignment between vision and the messages and the different policies. There is a lack of alignment between policies from different levels, ministries, health authorities, and there was a strong sense that this alignment is really important to create synergies to really move the system forward, but also to kind of avoid competing around restricted resources. The second one is around appropriate and sustainable compensation model. I think it's been well recognized that the fee-for-service model, where most physicians are still paid, is a hindrance to really promote team functioning and team collaboration. So the policy lever really is to look for alternative payment models that include physicians, but it was also pointed out that it's really important that we have a payment model that supports all healthcare providers and aligns their work with desired outcomes. So we can't just focus on physicians. It's important that we also look at the nurses and allied health providers and the support functions to make sure we find a compensation model that supports multidisciplinary team working. There was also a point made that the real issue is the separation of funding streams and that this needs to be reconciled. So currently we really have 2 systems. We have the health authorities in most provinces are paid through one pocket of funding and then the direct reimbursement of physicians. And there was a strong suggestion that this needs to be reconciled in order to move forward. The third one is invest adequate resources to system change. Team-based care will cost money, so there needs to be funding for infrastructure, integrated information systems, but also funding for more the softer team development, change management opportunities, which often get missed. And the other point that was made with this policy imperative is we need improved evidence to guide decisions on resource allocation. So right now we don't really have a good understanding how we should allocate resources. And I think that really links to the last imperative here, largely due to a lack of data and monitoring or evaluation of those models that have been implemented. So if we really want to move forward and make progress, we need to develop consistent measures so we can learn from the successes and failures of the different initiatives and the different policies and how they support that. And that means we have to set clear expectations for monitoring and evaluation in all of the initiatives, but we also have to invest in a data system and some shared indicators across the provinces. So in conclusion, we do feel that the 4 policy imperatives speak to the limitations evident in the current policies today, and we think these are key mechanisms that we can use to advance team-based primary health care. It has been pointed out by our policy makers that they're really very interrelated, so we can't just choose one over the other. That's why we didn't call them policy options, but imperatives. So we need to tackle them all collectively to really move forward, and then I think we have a really good chance to set a good foundation for a pan-Canadian approach to team-based primary health care. So I would like to pass it on now to Louise, my colleague. She has been involved in a very interesting but much broader initiative that looked at scope of practice of healthcare providers. That was a national study. But what we found interesting is that some of the same themes emerged from that study as well, which I think really provides support and validates the policy levers that we have put together here from our knowledge synthesis. Louise.
Thank you very much, Esther. Can everybody hear me? I know looks like I'm muted on my screen, but I'm hoping that I can be heard. Please send me a chat if you can't. So good morning for those of you who are west of the Rockies, and good afternoon for the rest of you. I think Esther really set this up very nicely in terms of why we are even presenting these two pieces of work together. This particular project that was going on pretty well at the same time as the study that Esther presented was sponsored by the Canadian Academy of Health Sciences and supported by the Canadian Health Human Resources Network that works out of Ottawa. Sorry, I'm just going to click on my slides. There we are. And it was called Optimizing Scopes of Practice, New Models of Care for a New Healthcare System. And in Esther's presentation, she actually talked about the importance of scopes of practice. The expert panel members, the way these assessments are set up is that they choose experts from across the country who really do act as a consensus panel and work with a support team, and this was the project team from CHURN at the University of Ottawa. I'm going to talk very briefly about the problem, the charge that came to us from the Canadian Academy, our assessment approach, our findings, summary, and of the key recommendations, but really focusing on those areas where there was clear congruence between what was found in the study that Esther just presented and our recommendations. Understanding that the scope of our project was much broader than the scope of the project that was previously presented to you. So the problem, right? Why would we even look at scopes of practice? And as we talked about this and looked at the literature, it became increasingly clear that our healthcare system has very much developed over a number of years based on tradition, based on politics, and really was set up to respond more to acute episodic care, which worked very well 25 years ago, but I think most of us would agree, particularly in primary care, this does not work. And so really, what is the specific problem that with the professional scopes of practice? Again, in looking at examples across the country and in the literature, we recognize that innovative solutions to our current issues worked around structural barriers, were not supported, that could not really achieve scalability beyond a very local context, and ended up really existing or coexisting in parallel to mainstream practice. And so the problem with the feeling was that we have a misalignment of our health human resource capacities that are not really responding to the healthcare needs of our population. And so the charge that was really presented to us by the Canadian Academy, with a specific question being, what are the scopes of practice that will be most effective to support innovative models of care for a transformed healthcare system to serve all Canadians? I will have to tell you, when the panel met the first time, we looked at this and sort of gulped, realizing that this was a very, very broad but important charge nonetheless. So how do models of care relate to scopes of practice? I will not spend a lot of time on this, and I believe you will have access to these slides, and you certainly can you have access to the report that we produced. But ultimately, on the left-hand side of your screen, we would need to understand, how do we even define population health need, and how do we design our system to address population health need? The far right is ultimately what we want to do is improved outcomes and have a healthier population. In the middle, we looked at innovative models of care and optimal scopes of practice, and how do the two relate to each other, because the understanding was you couldn't really look at scopes of practice if you didn't also look at innovation in our healthcare delivery models. And so the approach we used was a very traditional approach. We developed a conceptual guiding framework that did look specifically at macro, meso, and micro influences, and I will present a bit on that later on. looked at the published peer-reviewed and gray literature, and were able to extract a number of about 125 sources, and then based on that developed an interview guide and interviewed 50 Canadians and international experts in the area. All of this material was then presented to the expert panel, and we worked on this over 18 months to come up with a series of recommendations and also to be able to identify who in the system would be responsible for some of those, to enact those recommendations. Our conceptual framework looks busy, and it actually is reasonably simple. Again, on the left-hand side, we needed to say, where are we? What are we currently doing, and where are some of those issues that we really need to address? And they're listed there. I'm not going to read through them, and they relate very nicely with a lot of what Esther presented earlier. And then on the right-hand side, where do we actually want to be? What would a transformed healthcare system look like? What would be the characteristics of such a system? And then in the middle said, what do we need? What are those inputs at the micro, meso, and macro level, so micro being at the practice level, meso at the institutional level, and macro at the structural level. And what would be those enablers that would allow us to move from the left to the right? So our key research findings, basically we realized that there was an emerging consensus that paired with evolving models of shared care, we could provide a multidimensional approach to shift healthcare from one that is characteristically siloed to one that is collaborative and truly patient-focused, patient-centered. And so I drew out of a longer list of barriers and enablers using, again, the macro, meso, micro framework, and to show you the alignment with the study that was presented by Esther before. So this really is looking now at the macro level, so that broader, probably much more at the policy level. And what I highlighted in red where the alignment or the congruence occurs between our two studies. So looking at education, we do, from an enabling standpoint, we need to really foster interprofessional competencies. This actually needs to happen at the pre-licensure, i.e. before our young ones go out into practice, but it also has to happen once they're in practice. And we hear this all the time from our students who go out. We give them classroom-based activities. They get all excited. They go out into practice, and they come back and say, you lied. We couldn't find what you were talking about, even though we think that's what should happen, but it's not out there. So from an education, both pre- and post-licensure, we need to invest as a significant enabler. The other area at the macro level is what Esther alluded to, is the payment models. And we specifically tried to stay away from remuneration of physicians, and I think unfortunately people default to that all too readily. These are broad payment models, compensation models that will actually allow individuals to work in a team-based environment optimally within their scope of practice. So what alternative funding would we need, bundled or mixed, in order to achieve that? At the meso level, the two areas that overlap well with the previous study is the two issues of accountability and availability of evidence. Is to what extent do we actually have the metrics or the evidence? What kind of evidence do we need to guide the kind of practice? And then how do we hold our practitioners and our teams accountable for collaborative performance that really works within a quality improvement, a quality assurance framework? And we are sorely lacking in those elements. And then at the micro level, which really does relate, I think, back to the education, but it was more around changing professional cultures, looking at those issues of trust, of role clarity, of being able to really identify how do we work in a collaborative way when there is complementarity between our scopes, as I think Esther alluded to earlier. And so where's the continuing professional development to cultivate that team thinking and to develop levels of trust around our relative competencies? The other recommendations that are listed here I think are important, but as I said, I really want to highlight those that are congruent with the previous study. So our key messages, our recommendations, The first big message is a common characteristic of scopes of practice, models of care, innovations of right now that exist are that they largely circumvent the macro level structural barriers, those policy pieces that are not really facilitating and if anything sometimes get in the way. Other key messages is we do need an integrative structural framework that supports optimization of scopes of practice and innovations. And again, Esther talked about that, the alignment across the various sectors, that sometimes I think those of us in the field look out and wonder whether there's a lot of crosstalk that goes on between our various groups who set the policies and procedures for us. But at the same time, we need a certain amount of flexibility that allow the various contexts to have their own models that will emerge, but we also need to have accountability built into this. And that is actually a key element that I think we are going to need to step up to the plate and ensure that we've got measures in place to ensure to allow accountability to take place. The recommendations that I'm listing here and the priority actions are some of those that we listed in our report. First being the adopting alternative funding structures, right, which we heard a lot about from Esther's study. The second is to develop a national framework for guidelines and quality standards for optimal, expanded, and overlapping scopes of practice. Third, to embed and mandate interprofessional, competency-based education across the professions. And this is not an additional competency. These should be just an essential competency to how we do our work. The fourth is to work collaboratively with our professional certification bodies to create national standards and competency frameworks that recognize training and recertification. And this also relates to some of our accountability. The fifth is the support that's needed, and that was spoken about in the earlier study, for system-wide adoption of information technologies that foster optimal scopes of practice. IT alone is not going to do this, but we need really to look at the role of IT in support. And lastly, which again relates to what was presented earlier, is what are those performance metrics for collaborative care models? How do we let individuals know what they are? How do we actually build them collaboratively? And how do we ensure that our practices are accountable for those performance metrics? So what will this mean? The changes we propose are that the team should be constituted as a structure, not simply a notion within the healthcare system. And that this structure is through our funding models, through our team accountabilities. The second, we need to empower the team to determine the scope of practice of team members. And the third is to establish a pathway to meet those conditions around accreditation, credentialing, training. This is trying to pull together all of those. So in summary, our recommendations provide, and our report provides, a blueprint for action that really speak about education and the frameworks that are legal, regulatory, economic, and evaluative. And the second important point is that there's no magic bullet here, nor does this belong to only one group. We can't just look at government and say, make this happen. We have multiple stakeholders who have a responsibility to make this happen. Ultimately, our goal is for the transformation of scopes of practice and models of care to enable the future healthcare system to best meet the needs of Canadians. So on that note, I will pass it over to Carolyn McCauley, who will now speak to us about Alberta Health Services and probably some practical implications of what we've spoken about. Thank you.
Thank you very much, Louise. And I want to thank both Esther and Louise for clearly articulating my wish list of where the opportunities are for us to move forward. Now I'm having difficulty moving the slide forward. Oh, thank gosh, it's not moving for me.
So Caroline, if you just want to use the left and right arrows on the top bar and just click through them instead of using your keyboard, that might be helpful.
Okay, just right out.
So right next to the eraser, there should be some arrows at that top.
Right, perfect. Perfect, thank you. All right, so I'm going to speak today just to the Alberta landscape because that's really what I'm most familiar with. And just want to thank Esther for giving a really good viewpoint of the 3 provinces. Had the opportunity to sit down with my colleagues from the other provinces and really look at how we compare and how the opportunities, I guess, for improvement. But just a quick recap of what Alberta looks like. So within primary care, we have multiple stakeholders. So we work with physician clinics. We have primary care networks. And as Esther alluded to, a primary care network is an opportunity for multiple physician clinics to join together and look at some commonalities of health concerns within the clients or the patients in their area. And by collaborating together and forming a network, they are eligible for funding from the government at the tune of $62 per patient that is brought in through the physicians panel. And with those dollars, they're able to hire teams to support the care. We have 42 primary care networks across the province, and they have anywhere from 4 doctors to over 300 doctors. So really vary in terms of magnitude and delivery capabilities. And then we had family care clinics. And the family care clinics really came out of an Auditor General report really looking at the inability or the lack of having good patient care in certain strategic areas across the province. So really areas where we saw patients with high needs. 2 of them were urban centers, and then one of them was a rural center that was facing a number of their primary care docs were leaving their community. It was a community that had experienced a significant fire, and almost half of the infrastructure of the town was actually burnt down, and as a result, physicians really struggled. They didn't have their offices anymore. They lost them in the fire. Patients were leaving, and so a number of the physicians were leaving the community, and the community was feeling really at risk, so the government stepped in to support them with a family care clinic. The difference between the family care clinic and the primary care clinic from an interprofessional perspective is that in the primary care clinic, it really is the physician sitting at the board of governance table, looking at the population that they're hoping to serve, trying to identify what are the gaps in needs and services. In the family care clinic, Alberta Health Services is solely owns and directs those clinics. So it's not directed by a panel of physicians with Alberta Health Services sitting in as one of the members of the board, but it's actually directed by Alberta Health Services. And thereby we have the opportunity to look at it from a population health perspective. And we also have the opportunity to and we've heard some of the things around compensation. So compensation was a huge impact here. The physicians in an FCC are on more of a salary type of payment option, and it really has allowed them to be a stronger member at the table and allowed the team to have conversations about how they want to work and together as a team and how they want to deliver care. One of the other advantages we have in Alberta is we have one health service provider across the province. So this has really given us the opportunity to look at interprofessional practice from a provincial perspective, look at it from not only what's happening in primary care, but what can happen in acute care and in long-term care, home care, public health. So really looking at that broader opportunity for integration and also for policy development across our organization. And then as Esther alluded to, there's a number of key strategic documents that have been developed. Probably the primary one right now is the primary healthcare strategy. But then we also have documents like primary care network evolution, PCN evolution we call it, which was really led by the physicians in our province, again, based on the recommendations from the Auditor General report of 2012, looking at what are the necessary movement or levers that they need to consider as they move primary care forward. Obviously, team-based care was one of them, but they looked at them from a number of opportunities and levers. So that has really informed our practice as well. So I'm going to align my talk with the imperatives that Esther outlined and really speak to how some of them, I guess, the opportunities, we can speak to it that way, some of them still the ongoing challenges that we have and the movement going forward. So when we look at aligning health system goal, policy, workforce, and structures, we really look at some of the work we're doing around developing shared understanding. So when we look at the term, for example, team-based care, which is being used in primary care network evolution, what does that mean? What does that mean to the team? What does that mean to the physicians in the PCNs as they lead those networks? And how do they articulate that? So what does that look like going forward? And we have certainly within our primary care networks, because each of them are governed by their own distinct board, we have a huge range in terms of how the PCNs articulate team-based care. So everything from a fully integrated team where we see much more of the physician at the conversation working with the team to descriptions in PCN reports of having the team has supported the physician in getting their administrative work done and supporting them in having a quality of life. So really looking at what does team-based care mean, helping to define that, and how we bring in that patient perspective. So we are currently in the process of developing a patient-first strategy in our organization and really looking at how that informs that. We are moving towards greater alignment between Alberta Health Services, Alberta Health, which is the government arm of our health service delivery, and the Alberta Medical Association, the physician arm, and really looking at those opportunities to align all our strategies together and, again, develop that shared system understanding about what we're talking about when we move, move these things forward. And then lastly, we've got we're starting to look at greater alignment. So as we, within our own larger organization, so as we move forward, for example, in primary care, what does that mean in that acute care interface? What does our transitions to specialty care look like? How do we work together as an integrated team across divisions within our own organization as we move patients through the system and we allow and support continuity of care? Team-based care becomes a critical piece of this, as well as certainly looking at the IMIT component. And this was one of the things that we were able to achieve more strongly in our family care clinics. And the reason was, again, because we had AHS as the owner and operator, I'm going to speak to it that way, and the board of governance of those family care clinics was able to identify those pieces across the different systems. With the primary care networks, we have the physicians who are actually outside of Alberta Health Services. So our opportunities for that integration certainly has been, somewhat more challenged. Then looking at sustainable and appropriate compensation models, and we've certainly heard from Louise, it's not just about money. Unfortunately, one of the challenges and the barriers really has been our fee-for-service payment for physicians in terms of allowing them to be more fully participatory at conferences with patients, at meetings where we look at stronger team-based care, or we really develop those stronger teams. So that certainly has been an obstacle, and we found that in the FCCs where we were able to pay physicians on a different model, we have greater participation from physicians, and in addition, we have much more stronger team-based care. So we see better transitions of patients within the team, better movement of patients through the team, supportive documentation again. So that really has I guess, exemplified for us the importance of this work. Currently, there is some work looking at the patient panel Across the province, we have a number of PCNs who are sitting on significant surpluses, then we have some PCNs who are almost running at a deficit. So the challenge becomes, how do we distribute the dollars adequately across the system, and is there opportunity again for more innovation in these compensation models within our PCN structure? We do know currently that Alberta is looking at different compensation opportunities for nurse practitioners. One of the elements we've certainly discovered that we could benefit from more nurse practitioners in the system. Unfortunately, the payment structure is really difficult for them in primary care, and so we've had to, the provincial government is hoping to release some work around this by the middle of next month. Unfortunately, we are living in a resource-based economy in Alberta, and certainly we saw huge strides this past year in moving forward in team-based care and the whole importance of it within primary care. Right now, we're in a little bit of a wait and see in Alberta. As you probably recognize, we are a resource-based economy, and that resource isn't doing very well right now, and we're kind of holding our breath until March 26th, when we'll have our budget released. And we recognize that at that time, too, there may be some changes being made to those surpluses that I spoke of in the PCN. So PCNs have put forward requests around that, many of them addressing team-based care and improving access to patients to that team-based care, but we're in essence on hold right now, waiting for those approvals. And we really need to look at, identifying a long-term strategy to affect that change management within team-based care. I see we're running out of time, so I'm going to quickly move along. Just a little bit of innovation that's happening right now around monitoring. So we have a few things. With our province has released a primary healthcare evaluation framework, so looking at how we might move towards evaluating primary care, and team-based care certainly is one of those components. We have a larger initiative across our PCNs right now looking at a measurement capacity, so really working with the evaluators within the PCNs. Again, team-based care is a piece of that. Within our family care clinics, we've done work with both providers and with patients around team-based care to get some evaluation around where we are with that and how that's moving. And so we've got some comparatives to, because our FCCs have been running now for 3 years. Our struggle continues to be the IT to support this work, and also developing some consistency across the province. So we've got a lot of individuality between the different PCNs and not a lot of consistency at this point. And that's everything.
Thank you so much, Carolyn. That was an excellent overview of all the work that you're doing in Alberta related to this topic. And so I want to thank Esther and Louise as well for providing the research perspective at the outset. I did have a question for Caroline, but first I thought I would invite Esther and Louise if you have anything to add in light of what you've heard from Caroline while we're waiting for some questions from the participants.
Well, this is Esther. I find it very encouraging to listen to Caroline. So sometimes when you come up with policy imperatives, you don't know how realistic it is to really move forward on it. But I think she has demonstrated that we can make actually a lot of headway if we put our will to it. So that was very encouraging.
And it's Louise. I would certainly agree. I think I have often turned to Alberta to look at what you have been able to achieve, and yes, you've got still some hurdles, and unfortunately the financial situation may slow things down. But generally speaking, what I've been struck by, Alberta, is that you continue to build on what you have, and you really do look at lessons learned. So if something doesn't work, you don't necessarily just scrap it. You actually tweak it, build on it, and then and move on, which I think is really a great model for many of us to look at.
And Carolyn, it's Jennifer Campbell here. I just had a question. You mentioned the patient-first strategy that's developed in your province. I was wondering if you might be able to expand on that a little bit.
You bet. So it's currently in a draft version. It's receiving extensive consultation across the province, so both within Alberta Health Services, and I do believe there's a very strong patient engagement component to this. And really, because one of the things we constantly are hearing is the importance of having patient-centered care. So as an organization, we said, well, what does that really mean? And what does it mean to us as an organization? But also, what does it mean to the patient? Because, you know, very interestingly, right, as from a health service perspective, we can come in and say, oh, well, this is what we believe you think you need, right? And not listening to the patient is not helpful in gaining that understanding. So that is something that we are, and I believe it hasn't gone to executive leadership at this point for final endorsement. I think, Esther, if you know a little bit more, I believe it's still in the final versions of the draft, and we are hoping then to bring that to executive leadership and get that endorsement. But in primary care, it's something we're absolutely looking at. So how does the patient become part of that team? So when we look at interprofessional practice, what is the role of the patient in that team, and how do we support the patient? And then not only that, then how do we link them into the other supports that they have who they see as important members of their healthcare path? How do we link them into our team as well?
Excellent. It's certainly a large movement in other areas of Canada, and one of CIHR's, as probably most of you are familiar with, the SPOR initiative with the patient engagement element. So I did have a couple of questions I'm just going to direct your way. One from Carol. Is there any research demonstrating the benefits for physicians of moving away from fee-for-service payment models in favor of a model that better supports shared care and genuine teamwork? I'm not
Esther, do you want to go first?
I can speak a little bit to that. I do know that there's certainly, from the practice perspective, we certainly are able to articulate it from the perspective of the patient. So we do know that physicians that operate in a stronger team-based care model, we see better outcomes in patient outcomes, and we also see reduced cost to the system. So we do know that from that perspective, there is literature around that.
Yeah, this is Esther. Just to add, I think from a research perspective, the evidence is probably more about the fee-for-service as a barrier rather than looking at the integration of physicians, you know, if you have different funding models. So I think the better research part is the barrier to collaboration, and it's very clear that fee-for-service doesn't support physicians to be integrated into the primary health care teams.
And it's Louise. Certainly our report looked carefully at this issue, and I think one has to be careful when one starts to equate fee-for-service, capitation, or what have you, and really look at patient outcomes. Because in some ways you have to be careful what it is you're measuring. I think some of the earlier studies demonstrated that fee-for-service was actually superior in terms of patients getting access to physicians and for a number of visits. But you know, some of us could argue that the number of visits to see a physician doesn't necessarily mean better health. And so I think the feeling, generally speaking, is that exclusive fee-for-service is a barrier versus looking at more blended models. And but there isn't. I mean, you're right. There isn't a lot. There's certainly evidence of team-based care and better health outcomes for certain groups of population, geriatrics, et cetera, or the geriatric population. But when it comes to really trying to look specifically at the payment model for physicians and equating it to better outcomes, it may be that it's a bit difficult for direct linkages. But remember, we're not only talking about how physicians are paid, we're also talking about how teams are compensated. So funding models is probably what we really need to look at versus just simply how physicians are paid.
Thank you. Another comment here from Alex. Despite decades of discussion in Canada and evidence from the US and the UK, nurse practitioners still have a very small presence in primary health care in most Canadian provinces. And the question is, what did you learn from your key informant interviews about the basis for this gap?
I don't think the key informant interviews were really targeted to this kind of specific questions, but I was wondering if, Louise, if you have a good sense, because I think in BC the nurse practitioners are much more common than in Alberta, and they're much more integrated with the nurse practitioner-led clinics.
I am happy to comment on that, but I think this relates to something Carolyn said earlier. We are, now there are 3 universities that do educate or have nurse practitioner programs, and I'm fortunate enough to work in my own clinic with nurse practitioner students. The biggest problem is actually finding positions in primary care for these very skilled individuals because of payment models, is that there isn't a funding mechanism for them. And hence, either they're taken on in a group practice that is either a community health center type, and that's easy, but for physicians to incorporate nurse practitioners often requires very creative thinking and doesn't work. And so we have very talented individuals who are going into nephrology or going into very subspecialized care, which defeats the whole purpose. And I think the government's aware of that we do have a real problem around funding. So I would say I think the will is there, and I think that there's a much greater openness now, even among because I am a family physician, my family physician colleagues, to incorporate nurse practitioners, but we haven't yet been able to figure out how to pay them, other than, again, some very targeted funding that has gone to practices, but it's limited. It's not sort of system-wide.
I would totally concur, Louise. I think that's exactly what's happening in Alberta as well. And again, speaking to 2 of the models, we have the family care clinics. They made it a priority, and it was really to support improving access to healthcare providers. And so they're in the FCC model, it's a requirement to have nurse practitioners on staff, and so that has really facilitated that. But again, we have 3 across the province right now. Within our primary care networks, it requires the physicians on that panel to agree that this is an opportunity for them to provide another level of service to their patients. And the challenge is then it comes out of their funding for their network. And so we currently within our province have 1 nurse practitioner-led clinic that is struggling because they were hoping to get alternative funding opportunities through Alberta Health, that it has not materialized right now. And the PCN is really struggling with funding that clinic, because if they had a physician present, then that it would be a zero cost to the PCN to have physicians provide the service versus a nurse practitioner. So we're really hoping that the strategy that's coming forward from Alberta Health around the nurse practitioners will help address some of these issues.
Thank you, Caroline. I have another question here from Susan, wondering what the literature says about the optimal staff mix or scopes of practice within health professionals. That mix is for primary care teams, and if there's not much in the literature, how do we inform enabling policy or legislative decisions related to expanding scopes of practice for various healthcare professionals in a way that supports patient-focused care?
Well, this is Esther. I can take a first stab at that. So the short answer is no. The literature really doesn't speak to what an ideal team looks like and scope of practice. That's kind of the million-dollar question. So the recommendation we typically have is we have to look at population needs. So we really have to examine data that captures the population in our area of interest and try to understand what does the patient population look like, what's the demographics, what kind of health needs do they have. And based on that, we have to consider then what kind of healthcare professionals would actually be able to meet those needs. Now, to add an extra component, then we need to overlay our health human resources to that picture. So we need to understand what kind of healthcare providers do we have available in what kind of area of the province, because that varies quite a bit. We typically have enough providers in urban areas. We usually have a lack of providers in rural areas, and then only then I think we can actually start to think about, well, given our population needs, and this is what we have in terms of our healthcare provider population, is there anything that we need to add, and do we need to expand certain scope of practice of providers to address those gaps? So it's a fairly complex undertaking.
And I'll add, it's Louise. Esther's pretty well said what I would have said. Is, as a matter of fact, you don't want to have a prescribed mix of team members for a good, well-functioning primary healthcare team, because it totally depends on the population that the team is serving, and it also depends on where you are. Certainly, I can tell you, you will not have access to the same types of healthcare professionals when you're up in the remote areas of our province in British Columbia than you'll have in the Lower Mainland. And so I think the importance is more having the legislative frameworks that are flexible, right? And I think that is starting to happen. I think BC, I think Ontario, I'm not sure about Alberta, Carolyn, do have new legislative frameworks that allow for the flexibility and allow for individuals to actually work to their full scope, or at least as optimally as they possibly can. That's the key. It's not to try and determine that you need one of these and one of these and one of these, because it will look quite different depending. And even in the Lower Mainland, if your team is primarily serving individuals with mental health and addiction, you're going to need a different potential set or more of a certain type of healthcare professional than somebody working in another environment.
I would echo both of your comments. I think one of the things that we were looking at with our FCC model when we were moving forward with the 9 that were announced was really looking at what are the needs, the population health needs of the area, how does that best align, even considering what we would traditionally consider non-traditional health providers, medicine man, those kinds of individuals coming onto the team. And again, that would be for very specific and unique communities that we would bring those on. So I think the other thing we were really looking at, and especially for more of our rural and remote communities, was what are the opportunities for innovation with technology. So we were really starting to explore having potentially supporting those individuals within the community to really work at full scope of practice, but be supported by those higher level practitioners in another location. And what would that opportunity look like? So that was something else we were trying to explore, recognizing, for example, we're not going to necessarily be able to recruit a psychologist up in our rural remote communities. And if that's the actual gap and need, then how can we bring that service delivery? How can we support the team that's there to work to a really high full scope of practice and then be supported by a psychologist in another area? So really looking at that opportunity for innovation.
Thank you very much. I have a couple of postings on the chat, one from Carolyn and one from Nellie, just to draw your attention to these with resources that are available and links that are available from the Canadian Diabetes Association. Also, Nellie's listed some work in BC that's been done related to nurse practitioners and has provided a contact there. So it's great to see participants making linkages here and facilitating these connections for follow-up. So please continue that. We still have another 15 minutes or so for questions. And as well, Nellie's placed some links to several videos related to the role of nurse practitioners, how are nurse practitioners integrated into the healthcare team, and what impacts do nurse practitioners bring to the healthcare system. So thank you for that, Nellie. And the slides, someone asked, will the slides be shared? And yes, they will be shared after the webinar, and the video, the recording will be posted on the website. I think, Carolyn, you had mentioned earlier in your presentation about the IT challenges that have been presented, and just wondering if you could expand on that and what some of the next steps are. What are the challenges and what's being done?
Sure. So within Alberta, when a physician sets up their practice, so some of this goes back again then to policy and legislation. So in Alberta, there are 3 entities that can have custodianship over a patient's chart, one being a physician's and physician practice, one being Alberta Health Services, so our global organization, and the third one being a family care clinic. So just understanding that sets up challenges now when I run a primary care network, because I don't have custodianship over a patient's chart, and it requires me to have an agreement with the physicians. Within Alberta, there I think at one time there were as many as 7 different electronic medical records, EMRs, that physicians could choose, and again, chose a variety of them across the province. I think now we're boiled down to 3, but still those 3 do not talk to each other. We have lots of challenges. Even Alberta Health Services now has an opportunity for physicians to log on to NetCare and receive lab results from patients. But again, that sometimes is restricted, for example, to those physicians who work along our borders, because depending on what side of the street of the border you work on, depends on whether or not you have access. So, for example, Lloydminster, which is our border city, the physician practices on the Saskatchewan side, he's not able to access the Alberta data or lab records for his patients. So IT has just consistently been a challenge. Then when we start looking at how do we roll up and do measures, so let's say we wanted to do measures around access to primary care teams, right? How do we get the systems to talk to each other? Really difficult, first of all, to roll up even patient data on some of the systems, never mind comparing data across clinics. So within a PCN, they are challenged to compare data across the different physician clinics depending on the EMRs, depending on the ability to pull information from them. How was the EMR established? What were the parameters? What is it collecting? How can it be pulled? So it winds up being quite a complex problem, right from who all can have access to the data, what are the privacy impacts. So we do a lot of PIAs, privacy impact assessments, to see who all can have access, how can data be shared. And then that speaks to, even as we expand the team even better, as we look at a true primary health care team, which may include the community pharmacist, may include a mental health worker working in a not-for-profit organization. How do we even address those barriers? So what we have found is within our family care clinics, we've been able to be quite successful, again, because Alberta Health Services can be one of those custodians, and then we're able to link with the physician clinics because they're actually coming into the FCC using our health system and our EMR, so we've been much more successful there because, again, we're working with one system. As soon as we start working with multiple EMRs, we start having huge challenges, and then the custodianship becomes our other challenge.
Absolutely. Esther, Louise, do you want to comment or add anything there?
No, from my end, thanks.
No, I mean, I think from my end, having looked at this in various provinces as well, it's, and I'm certainly no IT person, I just can't help but think that the reality is you will have physicians' offices primarily, or primary care practices that will potentially using different EMRs. And Alberta, you're at least ahead of the game because there's 3 versus I don't know how many there are in BC and in other provinces. But surely we can somehow figure out a way of linking certain bits that will make it easier. And the custodianship, I think, is really an important one, the whole issue of privacy. But there are certain jurisdictions that have managed to, I think, get beyond this. And even if you look at the United States, there's some, with all due respect, that they don't have a system of care, but they've got some outstanding systems of care.
Yeah.
And so I still kind of scratch my head and wonder, why is this so difficult? Because at the end of the day, you know, we need to basically access information, and the patients need to access information. So it's not just about the providers. It's also being able to help patients access the information that can be helpful to them. Mm-hmm. And I'm sure that our folks who are from the Diabetes Association would say that a lot of this is really promoting the self-care or the self-management piece. So the opportunities are tremendous. It's just figuring out how we can overcome some of these really what seem to be insurmountable, but I can't help but believe they must not be. There must be ways around this.
Yeah. I think one of the opportunities, speaking of the U.S. system, is when you have an HMO, they employ the physicians, and they run the whole system. So I guess, you know, somewhat moving closer to the Alberta Health Services model.
Exactly.
Yeah, they employ the physicians, so the physicians use their EMR. They run everything from acute care to home care, long-term care, primary care. So they've got the whole system matched. They can track their patients going through the system. They're all sharing data. And I think that's, I know within Alberta we've even been looking at a personal health portal. So how do we give patients access to their medical information? And, you know, something that you think would be standardized at this point, for example, common measures around a lab data have not been standardized across the different labs across the province. Mm-hmm. So we're currently in the process of even going to a common lab deliverer, and one of the reasons for that is so that if iron range is X to Z, then it's X to Z for everybody, not A to B for some and X to Z for others, and not being able to post what normal values would be on your personal health portal, because we wouldn't be able to translate it across all the labs that were out there. So it kind of boggles the mind at how simple some of the challenges we get right down to basics. We just have not done a great job of standardizing things from the beginning and allowed people to move in directions, and now we're trying to standardize, which makes it a lot more difficult.
Yeah, understood.
Thank you for that. So I have another question here. This one is about the role of physician assistants. And has the role of physician assistants been discussed in your research? And how do you think their expanding presence might impact primary health care delivery moving forward? Sir Louise?
Well, we didn't look specifically at any one group in our work. I mean, I can speak about, and I don't know if there are physician assistants in Alberta or in Saskatchewan. Certainly, we do not have physician assistants here in British Columbia. I know there was a question of whether or not the government would fund PA education programs, but I think that's in large part when nurse practitioners were really starting to become more of the way we wanted to go. So I think certainly in BC, I don't think that physician assistants are I have no idea if they're on the radar screen, but I haven't heard much talk about them. I do know what's been going on in Ontario and Manitoba and the integration there. And so I think we see way more activity, Manitoba being the first, and Ontario now having quite a large number of physician assistants who are being educated every year with a certification process, et cetera. But beyond that, I would have to say that we didn't specifically look at PAs. Esther, I don't know whether...
Yeah, we didn't specifically look at PAs in this study, but Alberta is actually running a pilot initiative where they're introducing physician assistants into different settings, and our team is doing the evaluation for that particular project. And as you can imagine, because the scope of a physician assistant overlaps quite a bit with nurse practitioners, and so in terms of how successful the physician assistants are in different settings, it really depends on the role of the physician assistant. It depends on the context. Who else is already there? Do they have nurse practitioners? Do they have residents on a regular basis? Do they have physician extenders? Other providers that have overlapping scope? And what we found is it's really important in the beginning to look at who is there and how their role might change through the introduction of a physician assistant. So exactly the same you would expect with introducing a new team member to an existing team. I think it's really important to look at everybody's scope of practice and what it is they're doing and make sure that role is a good fit and where there's overlap, just to create clarity around who is doing what. But we have some very positive feedback from some of the sites where they really seem to be able to assist with patient care and improve access for patients. And patients have very, very positive feedback around the physician assistants too, because they tend to have a little bit more time than the physicians, so they can spend a bit more time with the patients, which they really appreciate.
And I'm not sure if all of you can see this posted, but from Joan, one also needs to consider optimization of the registered nursing role within primary care. She mentions research in Ontario that would suggest that they are often underutilized. So just a comment.
Ms. Louise, I'd love to comment on that. Certainly, for a number of years, having worked with what can also be called family practice nurses, I would agree. I think that the RN has a very broad scope of practice, and within primary care, I would agree that I think that they have been truly underutilized, and even when there is an RN present in a practice, he or she is not working to full scope and really should be. So I think there's a whole other area that needs to be worked on and probably invested in.
I know one of the opportunities we took when we were setting up our family care clinics was to really have the team sit down and talk to each other about what their roles and full scope of practice looked like. Because I think we've kind of gotten ourselves all into a situation where I think I know what a nurse does because I've worked with nurses for many years, but I've worked with a variety of nurses who all of them may to some degree not have been working to full scope of practice. So my true perspective is very limited. And when we actually sat down and had all our team members speak to what they did and what their full scope of practice really looked like, it was amazing how then we would go, oh, okay, well then I don't need to be doing that. That should be going over to you. And really had those conversations at the team level, and as a result really eliminated a lot of potential duplication, potential gaps, and also potential conflict that teams often experience when role clarity is lacking.
Yep, for sure.
Okay, so just looking at the clock here, we're nearing the end of our time, and I'm seeing some comments roll in, but no new questions. And I just thought perhaps I would give each of you a chance, just in 30 seconds or less, some concluding remarks, thoughts perhaps on the priority actions and what of those to be tackled first, whatever you like as we conclude this webinar. Louise, do you want to start?
Thank you. The difficulty in answering that is I actually don't believe that there's one priority action. Everybody wants to know, so where do we start? The reality is that I guess you have to start somewhere, but I would not be able to identify, is it the compensation models, is it really alignment, is it developing metrics, et cetera, that really should come first. I think what's more important is that the individual groups that are responsible for this, so government, health authorities, and others, really need to look at the 4 areas and figure out where are they in all of this. A bit the way what Carolyn just described and how Alberta has really gone through the 4 areas and figure out what can be done, what have they achieved so far and what needs to be done and who needs to do it. So really look at, this is not a menu you choose from. This is really, these are 4 areas that absolutely need to be done in tandem, and there's shared responsibility for achieving them.
Excellent, thank you. And Esther, your thoughts?
Yeah, Louise really summarized it very nicely. I couldn't agree more. As a matter of fact, when we had our policy roundtable, we came with those 4 policy imperatives. We called them policy options at the time and presented them to our stakeholder groups, which really were policymakers, decision makers, planners from the different provinces, and they were quite forceful in a way, telling us very early in the day, you can't call them options because there are no options, they're really imperatives, and we can't prioritize them. So they basically refused to prioritize them because they really felt they were all important. And so we had to change our days significantly and adjust the agenda just because there was such a strong sense that we can't pick and choose, but we really need to do all of them together in coordination. Otherwise, it's not going to move the system forward.
Thanks, Esther. And Carolyn, from the on-the-ground experience.
Okay. Well, certainly there's certainly a few rays of hope that I see. We are looking at across PCNs right now, really looking at supporting access, continuity, and attachment as being the foundational pieces to getting supporting primary care. And we know that as a result of looking at attachment, it's attachment to a primary care provider. Who is that? Is nurse practitioners involved in that? So it's beginning that conversation, getting that started. How are they being supported? So what does the team look like? We've got a couple of really cool initiatives in our province. They're called Triple AIM. So Triple AIM really looks at population health, experience of care, cost of delivery. And these are really looking at complex high-need patients. And what we've really discovered is that the team all of a sudden becomes social services, legal services, justice services. So really looking at now how do we work together in an even more complex system when we're all sharing the same patients and they're all going through all of our care. So how do we support continuity, right service delivery? So I think we've got some really innovative opportunities coming, and I know that we might be slower down a little bit because of the resource-based economy we have, but there's a strong will right now, even from physicians, to move this work forward. So I think we can expect some real movement forward in these next couple of years.
Wonderful. Well, I do want to thank each of you very much for sharing with us today the work that you've been doing. It's obviously taken, a great deal of time and effort to get to this point. And I'm sure that those on the teleconference or the webinar today and others are going to benefit from this. I do want to thank all the participants for engaging and sharing resources and tools through the links. That's fabulous to see. And just in conclusion, I will mention that there is an evaluation that will pop up at the end of the webinar, and we hope you'll take a couple of minutes to complete that. And the contact information for our panelists today. I'm sure they'd be more than happy to entertain any other questions you might have about their work, and myself or Howell would also be very happy to answer any questions you have about the CIHR's Evidence-Informed Healthcare Renewal Signature Initiative. So thanks again to everyone. Have a fabulous day, and we'll see you at the next webinar. Thanks very much.
Thank you all. Bye.
Bye now.
Much.